Dr. McBannett sought to set the stage for you to help you to understand the context in which we worked as a foundation. One of the things that he indicated was that at the time that we were involved in providing care for persons with HIV/AIDS, the national program was focusing primarily on education, and not much is being done to help those persons who are actually living with the disease. In fact, at the time that we started to work, a lot of misconception about HIV and AIDS reigned supreme. Even persons who are involved in the medical field displayed as type of insensitivity to persons living with HIV/AIDS. One case in point is that we had a woman from Trinidad come to speak, and we went to the ministry, was speaking with people from the Ministry of Health. And one of the leaders, a medical doctor, shook Yolanda's hands, and right after she left, first thing he went to do was to wash his hands. It was a very, very difficult time in which we worked. The National AIDS Program today, and Ronnie and the others working in this program, have systems in place that were not in place at the time that we were working. So people were very reticent to have their status known. And so it is because Dr. McBannett worked with persons that he would ask, would you like for someone to visit you? But otherwise, we did not know who had the disease. And so it was very difficult to make interventions. There were people in the community who suspected that some people had HIV and in some cases AIDS. And we would get information from those persons and then we'd seek to verify it. But it was very difficult at that time to do this. I was part of the home care committee as well as the counseling committee. I believe it's important for us to understand that when a person is confronted with a life-threatening illness, that person is confronted with an existential crisis. There are a number of issues that this person now faces: physical, psychological, social, spiritual. And sometimes we have a tendency to focus only on one aspect of the person's, the dimension of the individual. I remember when we were having our counseling workshop, that there were some people who wanted to get involved in counseling of persons with HIV and AIDS. And I asked a few of them, why are you interested in this work? And because at the time that we were working, there were not the kinds of drugs now that give people extended life. Many times people, when you heard that you had HIV, it was a death sentence. So a number of persons wanted to get involved in working with these people because they wanted to get them saved so they can go to heaven. Now that's not bad, but you cannot ignore the whole person. And so I had great difficulty with that, and that approach. What persons who have received a diagnosis of a life-threatening illness need more than anything else is accompaniment. The persons who are going to be involved in HIV/AIDS work must care, must be concerned about the persons who are now having to deal with the various issues that now will confront them. Kenneth Doka said that there needs to be at least 7 sensitivities to persons with life-threatening illnesses. The first one is sensitivity to the whole person, which I just alluded to. The second one is the sensitivity to the problem of pain and discomfort. I don't know if Dr. Antoine or others can say what kinds of advances have been made in the medical structure here in Grenada with regards to pain mitigation. But I have found that this is one of the areas that was very lacking. It is believed that persons need not have to suffer pain to the extent that many people suffer now. Some doctors are concerned about dispensing opioids. They sometimes are concerned about the person becoming addicted. And for a number of reasons. But you know, if a person cannot have their physical pain dealt with, it is difficult to deal with them, to talk with them about any other issue. I remember being referred to a patient at a hospital, and I have not been able to talk with her about her circumstance in any great detail, because all she was telling me, I am having a lot of pain. And so she had to deal with this primary need before she could deal with anything else. This third sensitivity is a sensitivity to honest, open, and mutual communication. We need to be able to listen, and we need to have the capacity to allow people to speak and to share how they are feeling, how they feel about what they are experiencing. Another sensitivity is to recognize and respect individuals' autonomy. When a person has a life-threatening illness, they become very dependent on persons for a number of things. I worked in a hospital environment in the United States. And one of the things that I noticed is how there is an evolution in how people even deal with propriety. For instance, a woman who comes into the hospital very concerned about how she looks. After a while, she just lets everything go. They are prodded, they are, and sometimes they are not dealt with as individuals, and so even in a hospital context, the doctors may refer to the person as the bladder in bed 2, or the heart patient in bed 5. The individuality, the autonomy, and people like to be involved in the making of decisions. And so sometimes when we have to help people, sometimes we want to take over everything. So we need to be able to allow these people to have some participation in decisions about their own lives. Another sensitivity is to the individual's needs. We spoke about the psychological, spiritual, and other needs. And there are sometimes needs that people have that we need to try to address as soon as we can, because for a person facing a life-threatening illness, time is not perceived in the same way as we perceive time. One exercise that Kenneth Doker speaks about is that you give people a match, a lit match, and you ask them to speak about major events in their lives. And he indicated as the match burns down, people begin to speak more hastily, more quickly. And for a lot of people who are watching their life go away, it is important for us to be very concerned that their needs are met. So for instance, a person who may have just a few months to live may want to do something that we may not, under normal circumstances, say it's okay to do. But because this is going to be important for their own psychological well-being, we would speak to them about the consequences of their actions. And when they still decide to do that, we try to be as supportive as possible. Even in Grenada, we need to be, as we work with people, to be aware of cultural differences. And cultural differences need not only apply to ethnicity, but cultural differences can apply to educational level, social, socioeconomic status. How one person approaches a disease might be affected by his or her own family culture. Some people might be stoic in their response. So we have to understand what it is that makes the person he or she is. And finally, the sensitivity that persons need to be aware of is the sensitivity of goals. In terms of a person who has a life-threatening illness, you are always changing, the goals are always changing. For a person, let's say with cancer, for example, who believes that maybe in the early stage of the disease there may be a cure, that's what that person thinks about, that's a goal. But as the cure seems very unlikely, the goal changes. And so you have to help people to understand and to be present with them as they deal with the changing goals. Let me just speak briefly about a number of phases. Life-threatening illnesses can be viewed as a series of phases. There's a pre-diagnostic phase, there's a diagnostic phase, there's a chronic phase, there's a terminal phase. And in each of those phases, people have to deal with a number of issues. In the pre-diagnostic and the diagnostic phases, for example, the stage of a person's existing wellness may very well determine how they accept or deal with the illness. There are a lot of people who are sometimes already dealing with a lot of crises in their lives. And then they get this news that, or there is the possibility that they will get this news. And so a lot of things have to be considered. What are the developmental tasks that they have accomplished and still need to accomplish? What kind of social support they have? What kind of economic and financial resources they have? Then you have issues in the diagnosis phase. People now have to assimilate the whole issue of their illness into their lives. People begin to ask questions like, why me? Why now? Why am I going through this thing? People sometimes begin to ask themselves, what is it that I have done that has caused me to get this? I'll rush through right now the chronic phase. In the chronic phase, that's a time that can be very, very lonely for the individual, because the acuteness of the news and the condition has passed. The person is now the patient and may have gone back to work. And so the kind of support that he or she may have received during the acute stage is no longer there. And from the outside looking in, you may think that everything is well. But the person is still dealing with a number of the issues with which they were confronted before the illness, and now the possibility of, they were dealing with a number of other losses. There are so many different losses that we are sometimes unaware of. And for a person who has a life-threatening illness, apart from material losses that they may have as a result of surgery, people now have other losses like interpsychic loss, image loss, things about dreams that they may never be able to achieve. So it's important for us to begin to understand this. I don't want to be much longer, so I'll close here.